Welcome, everyone, to the session entitled Assessment of Voice and Resonance. My name is Andrea Bertoni. I am the education consultant for speech, language, and related services, and I've been at DPI for almost 4 years. I am with Maya Braden today from UW-Madison. I will let her introduce herself in a few minutes when I turn things over to her after I do a little bit of introduction. But welcome. I'd like to thank the Wisconsin Statewide Parent Educator Initiative, or WISPE, for letting us use their Zoom platform today. And I always like to start these professional development sessions with a quick slide of quick resources for people. If you're looking to a couple of quick high leverage tools, I think, around the speech language impairment rule change, which include the summary of changes document, which I think is one of my favorites. The second one, revisions to speech language impairment identification, is a side-by-side of the previous rule with the new rule. And it's a good resource when you're looking at how have things changed from the previous rule to our rule right now. There's 2 sets of videos. One's a more general overview, and the other one, the Digging Deeper video, was from September 15th. And then absolutely everything that we're creating or doing this school year, we are putting on the DPI Speech Language Impairment Assessment Tools page.
Hi, everybody. Thank you for coming. My name is Maya Braden, and I am a speech language pathologist, and I have specialized in voice disorders, and resonance disorders, particularly in children, but also in adults for most of my career. I am not a school speech language pathologist, and so I will defer to Andrea and others on some of the specifics of working in the schools, but I have worked a lot with children, and wanted to talk today about assessment of voice and resonance and how that relates to some of the new rules. So I used to work at American Family Children's Hospital in the voice and swallow clinics and in the cleft palate and craniofacial clinic. And now I'm a clinical professor at UW-Madison. So today's learning objectives. We're going to review the administrative rule, define voice and resonance disorders. And you'll notice that I do split them up. We'll talk about them together, but there are some differences. We'll talk about different potential causes for voice and resonance disorders, because that helps in knowing how to evaluate and how to treat, and identify evaluation procedures that you can use in the schools to identify and characterize voice and resonance disorders. So what is a voice disorder? According to ASHA, I'm going to read it because it's very specific. A voice disorder occurs when a voice quality, pitch, and loudness differ or inappropriate for an individual's age, gender, cultural background, or geographic location. In addition to that, a voice disorder is present when an individual expresses concern about having an abnormal voice that does not meet daily needs, even if others do not perceive it as different or deviant. So there may be things beyond what the voice sounds like that impact somebody's daily needs, or in the case of school-based services, academic educational performance. How does this differ from a resonance disorder? We do group them together. They're together in the big 9. But a resonance disorder is a little bit different in that this is too much or too little nasal or oral sound energy in the speech signal. So we'll talk more about what that means. But rather than a voice disorder, meaning something with the sound source or the production of the sound, this is where it is resonating, whether it's in the nose or the mouth. And these can result from structural, functional, neurogenic causes, or sometimes even be due to mislearning. I'll talk about a bit about that. I would direct you towards ASHA's practice portal for both of these for additional information, resources. They really do have a lot of good information. Okay, so according to the new rule, how does Wisconsin define a voice disorder? It's very close to the ASHA definition. That a child's voice is impaired in the absence of an acute respiratory virus or infection. That makes sense, right? We're not going to qualify kids for services because they have a cold and are hoarse for a few weeks. not due to temporary physical factors such as allergies, short-term vocal abuse, so they screamed too loudly the day before and lost their voice, or puberty. Here are the different things that could be impacted though. Vocal volume, including loudness, too quiet or too soft. Vocal pitch, including range, inflection, or appropriateness. Voice quality, and vocal resonance. So this rule puts voice and resonance together, and we'll talk about different ways to assess both of those. All right. So, we think sometimes of voice and resonance as a low incidence disorder. The prevalence, this is a pretty wide prevalence, right? 1.4% to 23.9%. If you really want to dig deep and look into these different studies, they look at it in different ways, whether it's by parent report, whether it's by how many kids actually go to a voice clinic, whether it's by a screening. So somewhere in this 1.4 to 23% of kids having a voice disorder. Now, if we break it down, this is a little more specific, 3.9% of preschoolers. And then in certain populations, it's much more common. So one study found 94% of children born extremely preterm had voice disorders, with 58% of these being moderately severe. Why might this be? We'll talk a little bit about causes of voice disorders, but a lot of kids who are born extremely preterm have other laryngeal concerns, might have other respiratory concerns. Some of them have prolonged intubation, which can lead to issues with the vocal folds as well. And then 76 to 100% of children post laryngotracheal reconstruction, which would be an airway surgery for kids who have a compromised airway. So in some of these more medically complex kids, we might be seeing a much higher rate of dysphonia. And I would also say some of these, there's an increase in the number of children born extremely preterm or with some of these more complex medical conditions with improved medical care, and kids having better outcomes even with some medical complexities. So you may see more kids with voice disorders in the schools and not necessarily your classic nodules, some of these more complex voice disorders. How about resonance disorders? So we don't actually know how many students have resonance disorders overall. We know that cleft palate with or without cleft lip is about 1 in 1,000 births, but not all children with cleft palate will actually have resonance disorders after a cleft palate repair. Up to about 30% might. Submucous cleft palate, about 1 in 1,200 births. And then resonance disorders are also really high in children with dysarthria, apraxia, and certain syndromes. And so if you're seeing kids with dysarthria, apraxia, 22q, 11.2 deletion syndrome, and others, you may be seeing more resonance disorders as well. And we also know that relatively few SLPs in schools support voice. And I would say also relatively few SLPs in medical settings. So 4% of the caseload in pediatric medical settings, according to ASHA's healthcare survey of 2019. In schools, 15.1% of SLPs report serving children with voice or resonance disorders. And I do not have this stated, but most of the SLPs in schools who do support kids with voice or resonance disorders really only see 1 or 2. So it ends up being a relatively less seen area of disorders in the schools and in medical settings. But given the prevalence, there may be more of it than we are supporting. We do know that there is a social emotional impact of voice disorders. There have been studies looking at teacher, parent, and peer perceptions of voice disorders, of children with voice disorders, and just listening to voices, being asked to kind of rate them on a forced choice scale of a bunch of positive terms, a bunch of negative terms. Overwhelmingly, teachers and other adults and peers rate the children with voice disorders more negatively. And if we're talking about implicit biases, this may affect how kids are treated by their peers and in the classroom. We also know that children as young as 4 are aware of and impacted by their voice problem. Nadine Connor and colleagues conducted interviews of children with voice disorders and found that as young as 4, they were making comments of my voice feels scratchy or people can't understand me. And we know that this can impact social development as well as extracurricular choices, personality development. This is specifically the studies that have looked at how children were rated more negatively by their peers. This is a combination of quotes from a couple of different studies that kids have actually said about their own voices, kids with voice disorders. Things like, sometimes when I talk, I can't even talk. Sometimes teachers will tell me to talk louder and I'll tell them I can't. So think about kids in the classroom being told, you have to speak up, we can't hear you, and they can't do it. I couldn't keep up with things because of my voice. Or my friends, they'd be like, what'd you say? I couldn't hear you. So think of this, voice is really an important part of communication. So knowing that, how do we capture that? And how do we look at how voice might be impacting how students are doing in schools? So when we are planning a comprehensive evaluation, we want to think about the purpose. What are we actually trying to figure out? We want to find out what we have in terms of background information and history. Are we going completely blind, or do we know a lot of what's going on with the student? Have there been any presenting concerns? I would assume you're probably not going to see a student if somebody hasn't noticed a concern or brought a concern. So what are those concerns? What is the student's age and developmental level? What kind of resources do you have available? And also consider the need, as we talk about, for multiple assessment tools. As with any communication disorder, we're not going to assess it based on a single parameter. And I do just have to make the comment about medical considerations, but I also want to say a few other things about it. So of course, in a school, you can't tell a family that they have to get a medical evaluation. You can't require a medical evaluation for treatment. There are things that cause voice disorders that can be potentially health or life-threatening. And so best practice is that anyone with a voice or resonance disorder of unknown etiology should get a medical evaluation. And working in the schools, you would work in conjunction and hopefully be able to communicate with the medical team and with the parents. So just knowing that these are the American Academy of Otolaryngology's clinical practice patterns, that if dysphonia fails to resolve or improve within 4 weeks, the otolaryngologist should be doing a laryngeal exam. Because one, we don't know if it's anything that could potentially be dangerous, and also knowing how to treat it does depend on knowing what's going on. And again, ASHA preferred practice patterns are that all clients with voice disorders are examined by a physician. However, I will say the physician's examination may occur before or after the voice evaluation by the speech language pathologist. So if a student is waiting for an evaluation, or I'm going to back up. If a student is waiting for an evaluation, if there are barriers, that does not mean that we can't do anything and that we can't do any kind of assessment. We might be limited in what is going to be diagnosed, but I don't think that should limit speech pathologists from listening to a child's voice and seeing how is that impacting them academically.
Maya?
Yeah.
Can I just add that, when we're talking about getting a medical diagnosis, we need to make sure that it's clear that parents cannot be required to bring medical information to an educational evaluation. So it's really important. I know you said it, but I just want to stress it again, that we need to be working with families and healthcare providers. And in general, the messaging that schools should be working with families to get medical information needed. But if the school is requiring something, they would need to provide the medical assessment if the parent is not able to provide it. And so that's often a talking point that SLPs need to have with their directors of special education. Because if that medical information is required in order to determine eligibility for special education, then we need to work with families to see if that can be something that happens.
And would I be wrong in saying that you don't necessarily, like, you can encourage the families to seek that, but you don't necessarily have to have that before you start assessing?
Oh, that's correct. Right. And
Right.
that's what I was hearing you say too.
Yeah, that would also be ASHA's practice patterns, that we can begin that assessment even if we don't have a medical diagnosis yet. So resonance and cleft palate, this is from ASHA's preferred practice patterns. Resonance and nasal airflow assessments are conducted by speech language pathologists, and the SLPs may perform these assessments individually or as members of a collaborative team. This is just for reference. Many, if not all, children with a cleft palate or craniofacial anomalies are being seen by a cleft palate or craniofacial team. This is an excellent resource for who that team might be in your area. We also know that some aspects of voice and resonance can be evaluated in the school setting. And I will just, anyone with stridor, choking, breathing problems, these should be considered, not just impacting the voice. These could be potentially life-threatening. And again, I know we can't require a medical evaluation, but these are danger signs. If somebody has stridor, like noisy breathing and we don't know why, choking, that kind of thing. So again, when we're planning an evaluation, we want to look at the purpose of the evaluation. Are we trying to determine the etiology? We can't necessarily determine that in a school setting, right? That does require a medical diagnosis. But determining the functional impact, characterize differences in needs, determine potential for change, and determine eligibility for services. All of those portions of it, I believe we have a lot of resources that we can. I'm going to just quickly go over, this is from ASHA's practice portal recommendations for a comprehensive voice evaluation. So this is the recommendations for all the things that are assessed in like a voice clinic setting. And I'm going to talk through what all these assessments are and which ones you might actually be able to do in a school setting for characterizing the disorder and looking at stimulability for change and looking at eligibility. And then this is a similar slide related to cleft lip and palate. And then I'm sure at some point you've seen this slide before, the 4-part model for comprehensive assessment. So what I'm going to do is talk about these assessment tools that we might use in a voice clinic for assessing voice and where they would fit into this 4-part model for comprehensive assessment. Again, knowing that there are some things that we really can't do outside of a medical setting and some things that we can. So when we're talking about academic activities, these are things that I would start thinking about. Classroom observations. So how are children participating in discussions? Can they be heard and understood by their peers and their teachers? Are they participating in individual spoken activities? Like if they have to get up in front of the classroom to give a speech, or if they're called on in class, are there limitations to that? When we're looking at educational records, are they losing participation credit because they don't respond in class? Are there teacher reports of reduced participation? And then there are also teacher checklists that can be used to look at what's actually happening in the classroom. This is one example, and this is from an ASHA publication from 2004, so it's older. This is one example of a checklist that has been used in some districts that can be used as a parent or teacher checklist. But some of the things that they look at are complaining of a sore throat, differences in how the voice sounds, how they're using their voice. This is the Virginia Department of Education's checklist. So I'm giving these as examples, not saying that this is necessarily what you're going to use, but these are examples of ones that have been used. This is a little simpler. It's a parent checklist. So if we were looking at measures to involve the parent, this would be something that they could, respond with. Does he have a hoarse voice? Do they clear their throat frequently? Do they speak too quietly? Are there breaks in the voice? All of these things would help us kind of determine what impact are parents noticing, what impact is happening at home. And then this is a really busy slide, but these are for somewhat standardized student or parent report measures. And all but one of them are available at no cost, open access. So the Pediatric Voice Outcome Survey is a very short four-item questionnaire that's completed by parents. And I have links to all of these. Again, there's no charge for these. Pediatric voice-related quality of life is a 10-item questionnaire. This one can be completed by parents, but it was also adapted to be completed by children. And so there's a children's version of it too. So if we're looking at something more consistent to use for children, I believe it is 8 and up, their thoughts and impressions on how voice affects their quality of life. The Pediatric Voice Handicap Index is one that it is not open access. So it would require a subscription to the journals or the library. This is a 21-item questionnaire completed by parents. And then the only one for resonance is the VPI, velopharyngeal insufficiency effects on life outcomes, the VELO. And this one is commonly used in cleft palate craniofacial clinics, and there is a parent version or parent caregiver version and a child version. And then there are institution or district-specific checklists. Speech language probes. So how does that fit into voice? Case history kind of fits into that history. Do we have a parent report? Do we know medical history? Again, we can't require it, but we can ask parents if they would be willing to share that. Do we have a history of laryngeal surgeries, intubations, so vocal injuries, heavy voice use? Do they already have a pre-existing diagnosis of vocal fold nodules or a vocal fold paralysis? This can definitely help to plan treatment. Interviews with parents, teachers, child, so that this is more informal, but maybe asking very specific questions about how does the student use their voice? How is it impacting them in the classroom? Narrative samples. So can we assess voice and resonance in multiple contexts? Is there a difference in how they're using their voice in the classroom versus in a quiet room versus on the playground? Stimulability, dynamic assessment. Stimulability ends up being very, very important in assessing voice and resonance. In determining potential for improvement, in determining actually the cause of the issues sometimes. And play-based assessment, so you can get a voice or speech sample from a child when they're playing. So I would reiterate, if you are taking these for both voice and resonance, it's great to record it. If you think about if you are going to be treating a student for a long period of time, voice is very perceptual, very auditory perceptual, and anything that's purely auditory perceptual does tend to lend itself to being a bit of an auditory bias. So it's really hard to remember exactly what someone sounded like 6 months or a year ago. So if you have a recording and you can listen and compare changes, you can also listen and compare, are there differences in the classroom, on the playground, in noisy and quiet environments, in higher and lower stress situations, with increased cognitive or emotional load. All of these are going to help guide your observations in and determine eligibility and plan. And then dynamic assessment or stimulability. So in voice evaluation, we do so much assessment of potential for change, because it really does help us determine potential for improvement with therapy. So this voice therapy is beyond the scope of this presentation, but if you have done any training in voice therapy, you know some of the strategies we use. Semi-occluded vocal tract exercises, lip trills, straw phonation, bubbles, humming, cues to be louder or softer. Do they know how to increase or decrease loudness of their voice? cues to take a breath, use airflow. And resonant voice therapy is another very commonly used therapy approach. Or in some cases, would any assistive technology like an amplifier improve classroom function? So all of these, we as skilled providers can gather a lot of information on what is helpful. Resonance, I would say even more so. Later, I'm going to talk a little bit about some differential diagnosis in resonance, but sometimes kids get picked out as having a resonance disorder when they actually have more of an articulation disorder. They might have phoneme-specific errors that might be stimulable for correction just with therapy. Do things change with nasal occlusion? I don't know if y'all remember back to graduate school talking about the cul-de-sac test, or if you plug a child's nose, are there changes in their resonance? So if somebody says, pet the puppy, let's say they sound really hypernasal, pet the puppy, you plug their nose, pet the puppy, it sounds totally normal. That's information about what's happening. Whereas if you plug their nose and they say, like they're trying to force it all out of their nose, that's something different happening. Does the child alter their resonance with models or cues? If you give them cues to make that come out of your mouth, do they do that? And that, again, gives you information on how they might do with some therapy. There are a couple other types of errors that therapy can make improvements with. So compensatory errors. Kids with cleft palate do a lot of compensations. I would say kids are smart. They really try to figure out how they can make the sounds that they don't know how to make, given the structure that they have. So this would be glottal stop substitutions. So thinking about kids who might say, instead of go get a cookie, oh, they're trying to create the stop here in their throat because either they can't or they don't know how to create the stop here. Same with pharyngeal fricatives, like instead of Susie sees a dress, nasal fricatives where they make it in their nose. So these can be due to inappropriate structure, but they also can persist after structure has been repaired. So you can have kids who have glottal stops who've had a palate repair, but just haven't figured out how to make the sound correctly. That is more of an articulation error and not a structural issue. I will also say in some cases, for other medical reasons, for timing reasons, surgery has to be delayed. While you're not going to change the structure with therapy, there are some things that can be helped with therapy prior to surgery, where kids can start learning an appropriate placement before the surgery. Velopharyngeal mislearning, I find fascinating. So these are velopharyngeal errors with intact structure. So these are really, again, more articulation errors. They can be resonance errors as well. But take, for example, phoneme-specific nasal emissions or substitutions. So if a student only has nasality on a couple of sounds, that's probably not structural. So let's say you've got a kiddo who has all their P and B sounds. They sound great. Doesn't sound hypernasal on those, but their S's come out of their nose. They go, but then they say puppy. Good chance that is a mislearning. You can also have residual hypernasality after a structure is fixed. So if someone has velopharyngeal insufficiency due to either cleft palate or non-cleft velopharyngeal insufficiency, they have that repaired, but they've been talking a certain way their whole life. They may have residual hypernasality. And in very rare cases, a functional resonance disorder. So students who are hypernasal for no known reason. This is just sort of what they started doing. One sound I see this on, not super often, but occasionally, is nasalization of R. So instead of kind of a classic glide, you get an NG sound almost. So instead of car or cow, you get kang. and it can really make them sound hypernasal. But if you break it down, they're not hypernasal on other sounds. When we're talking about how are we assessing things, contextualized versus decontextualized academic activities, there are more formalized ratings of voice and resonance. So I've talked about, taking speech samples, taking narrative samples, keeping track of your observations. I'm going to talk about some very specific rating scales that you can use across multiple settings and in context. So again, I talked about taking these narrative samples in the classroom, outside of the classroom, but how do you measure that? Can you just say, well, they're hypernasal, or well, they're hoarse? There's some more structured ways of looking at that. So dysphonia and resonance disorders are identified with the ear, right? It's a little bit like if a tree falls in the woods and nobody sees it, did it really fall? If a child or a student or an adult or anybody has a voice disorder and nobody can perceive it, including themselves, do they really? But there are different ways of quantifying or describing these. And there are some consistent scales that can be used. These do fall under all of the challenges that we have with perceptual ratings, that they do depend on listener skills, listener experience. There are different biases. You can have, depending on, if you've heard a whole lot of dysphonic voices, you might rate them as less dysphonic, recency bias. If you expect them to be getting better, you might rate them as better because of a confirmation bias. So you have to be careful with these. I do feel like recordings and listening to a lot of different voices help with this. So I'm going to use some vocabulary on how do we characterize voice. Pitch. I feel like that's usually pretty obvious to people. Pitch is the perceptual correlate of frequency, though. So pitch, we think of as how high or how low the voice. It is correlated with literally how fast the vocal folds are vibrating, right? So if you remember back to speech science, hertz, cycles per second of vocal fold vibrations. Loudness, perceptual correlate of intensity. And so when we're looking at this in students' voices, are they too loud for the situation? Are they too soft? Do they have difficulty getting loud or getting soft? And is this impacting their ability to work in quiet groups? Can they not get quiet? Or is it impacting their ability to present in front of a classroom or be heard? Breathiness. So breathiness is this perception of excess air escape in the voice. So you can kind of visualize the vocal folds are not fully coming together. Breathiness can be caused by a number of different voice disorders, but essentially it's that there is too much air escape. Roughness is a descriptor that really describes the perceived irregularity in the voicing source. So roughness, like this is an extreme level of roughness right here, right? So really gravelly, that kind of bumpy, scratchy voice. And then strain is perceived excessive vocal effort. There are terms that as you get used to using them, you can quantify and describe voice characteristics. So I'm going to give you two scales that are used in the voice world. This is a very straightforward, simple one. Originally came out in the 1960s, actually, and then was published in a book in 1979. So this looks at different parameters of voice grade, meaning overall severity. Roughness, I just talked about roughness. Breathiness. Asthenia is not a term we tend to use quite as much as roughness, breathiness, and strain, but asthenia sort of refers to weakness of the voice, and then strain. And then this goes on a scale of 0 to 3, 0 being normal and 3 being severe. So I actually use this a lot in treatment sessions. I will make a quick voice rating at the beginning and end of a session to see if there are changes. So this, for example, would be grade of 2, so moderate overall, roughness of 2, moderate roughness, breathiness of 2, no asthenia, and strain of 1, mild strain. Is it perfectly objective? No, it's a subjective perceptual scale, but it's quantifiable. This is a different scale that is probably used even more commonly. This is the Consensus Auditory Perceptual Evaluation of Voice. And you can actually access this on ASHA.org. It's free for download for non-commercial purposes. It's straightforward, but not necessarily easy. It consists of multiple 100-millimeter lines, and the listener puts a mark on the line and measures it with a ruler. And the marks would go for overall severity, roughness, breathiness, strain, pitch, and loudness. With the CAPE V, it was intended to be used with certain specific stimuli. And the idea is that we perceive voice differently in different contexts. So with this, there are specific sentences to be used, as well as sustained pitches and connected speech. So again, that's, assessing in multiple contexts, not necessarily completely contextual. It doesn't necessarily include a lot of academic activities, although you could foreseeably use it in the classroom as well. If this is one that you want to use, but you're just not used to listening to a lot of voices, this is actually a free resource for voice training, available on this website. There's a link. So when you have the participant folder, you can link to this. It's free. You can listen to 296 audio files with CAPE V ratings by 2 or 3 voice specialized SLPs. So you can actually do your own practice and compare it to what other people thought. So the CAPE V is supposed to be used with certain stimuli, including sustained vowels, specific sentences. They're a little silly, but there are reasons for them. They all include different phonological contexts. So the blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama made lemon muffins, and Peter will keep at the peak. And then connected speech. I'm moving on to a perceptual rating of resonance. I have a link to this paper because it is a very structured rating tool for rating resonance and cleft-related speech errors, but it is not open access. So I'm going to talk about how kind of some of the parameters of this without actually using the instrument itself, because it's not open access. If you are interested in it and have access, this is the link to it. It's used in a lot of cleft and craniofacial clinics as well as in a lot of research, but specifically looks at all these parameters: intelligibility, voice, resonance, nasal airflow, grimace, which means does the nose wrinkle when they're trying to produce certain sounds, and could that indicate that they're basically trying to close their nose from the inside, and consonant production. Resonance, just for a few definitions here. I talked a little bit about a resonance disorder. Resonance exists on vowels and voiced consonants, but not voiceless sounds. So we can't say their P sounds are hypernasal, because technically they're not. Resonance has to do with the vibration, sound energy in the nose versus the mouth. So hypernasality is too much nasal energy. So if someone really sounds like this, so you really have a lot of hypernasality. Hyponasality is more what you sound like when you have a cold. You've got too little nasal energy. So like, by Bob Bade Buffets. Cul-de-sac resonance is a little bit harder to pick out, and I'm terrible at demonstrating it, but it's kind of like, it almost like the sounds a little muffled, blocked. And then mixed resonance is where someone might be hypernasal on some sounds, but hyponasal on others. So they might have enough nasal blockage that their M's and N's sound hyponasal, but they still have some nasality on vowels. Both the Cleft Audit Protocol for Speech, the CAPS-A, and I personally would use a rating scale of 0 to 3, kind of like the Gerbus scale, of none to severe, or up to 4. So this is what's used on the CAPS-A. The hypernasality, so 0 is no hypernasality. I like that this gives operational definitions, although sometimes they're not totally perfect. Sometimes it's hard to kind of figure out whether somebody fits into a mild, minimal, mild, or mild or moderate. So if you think about minimal, It's detectable to the trained ear. It's not impacting intelligibility. Could even be a dialectical difference where certain regions have a little bit more nasality in their sounds. Mild, detectable on high vowels. So E tends to be one where we hear more hypernasality on. Moderate, kind of detectable on high and low vowels, and then severe would be noticeable on all vowels as well as voiced consonants, and often might also translate to having reduced oral pressure on pressure consonants. Hyponasality, you can also rate this from no hyponasality, minimal, slight denasalization of nasal consonants. Maybe the M's and N's sound a little like you got a mild cold. Mild, slight denasalization of nasal consonants and adjacent vowels. Moderate, noticeable on nasal consonants and vowels. And then severe would be total denasalization of nasal consonants and noticeable on vowels. So like, again, can't do their M's and N's because it just sounds like by Bob. Nasal airflow is maybe a little trickier. So remember how I said resonance is only really on the vowels and voice sounds. Audibles and nasal airflow occurs mostly on consonants. Nasal turbulence, you hear is like a little rustle in the back of the nose often. So like almost like a kind of backward snort on the inside. So you might have puppy, little rustle there. Whereas an audible nasal emission might even be harder to hear, even though it indicates more airflow. Puppy. You've got a little bit more airflow, but not that rustle or frication. You can also differentiate passive nasal airflow, meaning somebody's producing the target sound and they're just having air escape. So like puppy, versus active, which would be a redirection of airflow through the nose, more like you can actually hear most of the sound is actually being directed through the nose. Take some listening. There are some good resources for ear training if this is something that you think you're hearing in one of your students. So here are some good resources for ear training. If you want to listen to different levels of hypernasality, listen to different cleft or velopharyngeal insufficiency related speech sound disorders. I'll probably be referencing the Leaders Project multiple times. They have some fabulous videos. They've got this whole Train the Trainer program where you can watch all kinds of videos on assessment and treatment of cleft palate and resonance disorders. So again, just like voice and resonance, and just like those in the classroom, we want to assess in multiple contexts. Quiet, competing noise, higher cognitive load, different times of day, especially with voice and resonance. Sometimes the voice can tire out by the end of the day, or the ability to kind of continue to maintain their optimal effort can fizzle out. So assessing someone at 8 a.m. versus 3 p.m. might be different.